All right, so welcome to part two of the talk. So now that we have a pretty good understanding of what post-traumatic stress disorder is, we'll talk a little bit about how we would go about treating post-traumatic stress disorder. So the outline for part two, so part one, we looked at what is PTSD. Part two, we're going to look at a couple of different cognitive behavioral therapy techniques for the treatment of post-traumatic stress disorder. So we'll start by looking at evaluation, then we'll discuss psychoeducation, and then cognitive restructuring and exposure. And so first thing that we would want to do in therapy with a client who's experiencing post-traumatic stress disorder is evaluation. So first we need to evaluate both the symptoms of PTSD as well as the associated factors. So what we would start with is a review of the traumatic event. We would go through this very briefly and in not very much detail. The reason that we wouldn't want to get into this too much is that this might actually create too much distress in our clients. So what we don't want to do, particularly quite early in the therapy, we don't want to introduce a lot of distress or create the possibility of dissociation. So we would ask them to review the event in a way that gives us a general understanding of what has happened, but without kind of creating additional trauma. Then we would want to understand what's the current level of functioning of this client. So how are they functioning in their relationships, in their home life, at their workplace? We would want to get an understanding of some of the pre-traumatic event factors that we discussed that could be risk factors. And so things like home environment, maybe a history of traumatic events, particularly if they occurred in childhood, a history of any mental health issues, anything like that. And we would also want to understand maintaining factors, things that might be sort of maintaining the symptoms of post-traumatic stress disorder. Then we would likely have them fill out some questionnaires. So filling out something to give us a sense of the impact of the event, often called just an impact statement, as well as some standardized scales assessing the presence of different symptoms of PTSD. The other important thing that we would want to do in an evaluation session is to evaluate the objective security of our client. And so there's a couple of really important things that we would be on the lookout for here. The first is our client in a safe situation to be able to start therapy? And so, for example, if a client is coming in with PTSD related to domestic abuse, we would want to make sure that the client is not currently living in a situation where domestic abuse is occurring, because that doesn't create a safe situation for us to start therapy. Additionally, we want to make sure that our client is not actively experiencing suicidal thoughts or ideation, because we want to make sure that our client is in a safe space and not a harm to themselves before we would be getting started with a trauma-focused therapy. So once we've completed the evaluation, we would move on to psychoeducation. And so what this is just providing information on PTSD and providing information on the treatment itself. And so a lot of what this can do is to validate the reactions that occurred during and after the traumatic event. And so symptoms of PTSD, we can really understand them as a normal reaction to an abnormal event that's occurred in your life. And so experiencing really extreme fear is very powerful, and it might lead us to engage in a lot of survival behaviors. And so when we understand that within that framework, we can also kind of work to validate what our clients are going through. We also might work to validate some of the emotions that the client might be experiencing. So things like anger, anxiety, shame, guilt, feeling disconnected or feeling powerless. All of these are things that we might expect when working with somebody with PTSD. So we would really want to work with the client to kind of educate on why these things might be occurring and how we can understand them as a perfectly valid response to the traumatic event. We might also spend some time at this stage explaining other people's reactions. And so what we find when somebody has experienced a traumatic event and is dealing with PTSD, they might experience negative responses from the people in their lives. So things like blaming the victim for the trauma, blaming the reaction of the victim for the trauma occurring, or blaming, the timeline of the symptoms. This happened 3 months ago. Why haven't you gotten over it? And so what we would want to really do is spend some time here to kind of provide some education on how other people's reactions are often a way for other people to feel like they have, control and safety in their own lives, and that it's not necessarily about the victim at all, but more about this person maybe not wanting to accept that the world can be an unsafe place, maybe wanting to control, their own discomfort around their loved one dealing with these symptoms or dealing with the aftermath of a traumatic event. So we'd spend some time there as well. And so I'm going to talk about two different techniques, two different CBT techniques that we might engage in when going through CBT for PTSD. And so the first is cognitive restructuring. So this is pulled from a therapy called cognitive processing therapy. The overall goal is to help with this feeling of being stuck in thoughts about a trauma. And the second technique that I'll discuss is exposure therapy. And so this is pulled from some people have called it prolonged exposure therapy or emotional processing therapy. And the goal of this is to enhance emotional processing of traumatic events. And so we'll start with cognitive restructuring. And so talking a little bit about some of the techniques that might be used in cognitive processing therapy, which focuses in quite a bit more on the cognitive aspects, the thoughts and beliefs. And so in this therapy, what we might focus on is the conflicts between the pre-trauma beliefs about the self, about the world, and about other people, and the post-trauma beliefs. And so what we might see is something like a pre-trauma belief that the world is a relatively safe place, and a post-trauma belief that the world is dangerous and bad. The way that we would go about this is first we would have a client read an impact statement to the therapist, discussing the meaning of this traumatic event in their lives. By reading this and having this discussion with the therapist, we'll be able to identify these cognitive distortions, or what they call in cognitive processing therapy, these stuck points. And they call them that, they describe them as a thought that might have kept you stuck from recovering. So this might be something like understanding why the trauma occurred, thoughts about yourself, about others, or about the world that have changed. These thoughts might look like if-then statements. So, if I hadn't gotten in the car, then we wouldn't have had that accident. And they might use extreme language like always or never. So I'll always feel this bad, things will never get better. And so these kinds of thoughts can be understood as maybe keeping somebody stuck from recovering. And the goal of this therapy and the goal of cognitive restructuring is to shift these negative patterns of thinking and belief about the trauma into something more adaptive. And so the way we would go about this is first, as we said, we would want to identify what is the distortion, what is this stuck thought, and then we would want to spend some time challenging this thought or this belief. And the way that we might go about that is by asking, well, what's the evidence that this is true? What's the evidence that it's not true? So we would go for what's the evidence for and against this? And then maybe asking some other questions that might challenge. So is this thought balanced or is it extreme? Are there other factors that we might be ignoring in this thought or this belief? We would also spend some time here identifying patterns of thinking. So there's a number of different patterns, unhelpful thinking styles that a lot of people engage in. And so we might try to identify, are you jumping to conclusions with this thought? Are we engaging in exaggerating or minimizing? Are we using emotional reasonings? I feel this way and therefore this must be true. Maybe we're engaging in mind reading, thinking that we can tell what somebody else is thinking or feeling, or maybe we're just ignoring important information that might kind of have an alternative thought. And then finally, we would spend some time creating an alternative thought. So creating something that's maybe a bit more balanced and that might help to sort of move through processing this traumatic event. And so an example of how this might work, if we were working with a client who this traumatic event was a car accident, an example of how cognitive restructuring might work if the thought that we're identifying is this accident was all my fault. We might ask some challenging questions. So, was anybody else involved in the accident or was it just you? Were there other factors that might have been at play here? So things like weather or car trouble. how can we divide the responsibilities? And working through this with the client, we might hopefully arrive at an alternative thought, perhaps that there were many factors about this accident that were beyond my control. And so you can see here that we didn't go, an alternative thought is ideally something that's more balanced, but that doesn't necessarily shift to the other extreme. And so an example of the other extreme of the accident was all my fault was this accident was all maybe somebody else's fault, or this wasn't my fault at all. Alternative thoughts, we want to get something that's a little bit more balanced. There might have been aspects of this car accident that were this person's responsibility, that did lie in the responsibility of our client, but there might also have been many factors that were beyond their control. And so ideally, what we want to arrive at with cognitive restructuring is a balanced thought that helps to kind of remove some of those stuck points when people are thinking about and processing this traumatic event and processing the meaning of the traumatic event. And so in a longer term sense, what this might look like is starting with specific thoughts, but then maybe moving as we go through the therapy into more core beliefs about the self or the world or others. So maybe the world is a dangerous and unsafe place, and applying kind of a similar pattern here. The other technique that we might use is exposure therapy. And the goal of exposure is to enhance emotional processing of the traumatic events to diminish PTSD and trauma-related symptoms. And one of the tenets of exposure therapy is relating to trauma is that the memories about the trauma are not the same as the trauma itself. And so if you recall from when we went through all of these symptoms, what we find is that people are sometimes avoiding either thoughts or memories, kind of engaging in internal avoidance about anything that might remind them about the traumatic event. People might also be engaging in external avoidance. So maybe avoiding certain situations, certain people, certain places that might remind them of this event. And so the way that exposure therapy works is that we'll expose our clients to trauma-related thoughts, images, and situations through both imaginal and in vivo exposures. At the same time, we'll also teach clients kind of relaxing and grounding techniques that they can use in distressing situations. And so what this looks like is breathing retraining, so learning to take deep, calming breaths in situations that are distressing, using techniques like progressive muscle relaxation, even meditation to kind of bring down some of that physical arousal that can occur when we're feeling very distressed. And so how does exposure therapy actually work? And so as we've said, we know that in PTSD, what we often see is some level of avoidance of remembering a trauma, avoidance internally or avoidance externally of a specific situation, person, place. What we know about avoidance is that it has a tendency to maybe increase fear over time. And so exposure helps to reestablish the fear structure and show that these thoughts, these feelings, and these situations might actually be safe, even though right now we are perceiving them as unsafe and reacting to them as unsafe. And so the goal of exposure is to slowly habituate to these emotions, to fear, to anxiety, to any other emotions that might come up over time. And what we see is that with exposure, we tend to see an overall reduction in these emotional responses over the course of many exposures. And so, for example, if somebody was in a car accident, they might be avoiding a certain street corner for fear of having maybe a emotional reaction and remembering aspects of that traumatic event. And what we tend to see is that by avoiding that street corner, we also are sort of reinforcing the idea that this street corner is dangerous. And what we know logically is that the street corner is not, in fact, a dangerous place, but that what's dangerous about it for this person is that it's associated with this traumatic event, it's associated with this memory. And so what we want to do is to create, habituate to these emotions over time and to create an exposure hierarchy. So what we do is we start very small and then we take small steps forward. So in vivo exposures are one type of exposure that we might engage in. And this is an in-person exposure to a safe situation, a safe person, anything that's done that you're actually there for it. This can be done alone as therapy homework, or it can be done in session with the therapist. And so often with in vivo exposures, we get kind of creative in the sessions, depending on what the exposure looks like. And in vivo exposures, in any kind of exposure, it's really important that we maintain a focus on remaining in the present moment. And so we've talked a little bit about dissociation. So dissociation is sort of that feeling of being really disconnected from oneself or one's body. It's a mind's way of protecting itself. We do see that people who have been through a traumatic event are at a much increased risk for dissociation. And so it's important, this is part of why it's very important to start really small with exposures. We need to make sure that the client feels safe enough to stay in their own body, to stay in the present moment, and that we have a level of anxiety that is tolerable and that we can kind of sit through and wait through. And so, for example, an in vivo exposure example, coming back to this same example of a car accident as the traumatic event, what we might see is maybe the first in vivo exposure is that we're going to sit in a car together. We're not going to drive the car, but we're going to sit in the car, maybe outside of the therapy clinic. Maybe we're going to start by sitting in the car during the session with the therapist, and then slowly work up to sitting in the car alone. Maybe our next step on the hierarchy is going to be driving around the block. And then maybe a final, the highest step on that hierarchy is going to be returning to the scene of the accident. And so maybe that would be an aspect of therapy, would be spending a session going to the scene of that accident together. And so these are 3 examples of kind of steps that might exist on the hierarchy. It's really important here that we would start very slow and we would spend quite a bit of time at each one until we can see that anxiety responses have come down, and then we would move on to the next. And then we also have imaginal exposure. And so this is an imagined exposure to a specific memory, a scene, or a memory of the traumatic event itself. The purpose of imaginal exposure is often practical. There are perhaps things that are not reasonable or not safe to do an in vivo exposure with. And so what we might do instead is introduce this kind of vivid imagination technique. These are typically conducted during the sessions with a therapist, and they use that same gradual hierarchy technique. And so in the event, so perhaps we want our client to recall the traumatic event with the therapist. And so we might have somebody do it a number of times, slowly becoming more connected with that story as they tell it. And so, for example, in a first telling of the story, they might give a very kind of bare bones, brief description of what the event was. And again, we might just sort of sit with that, remain in the moment, and habituate to those emotions. And then when we tell it for a second time, we might be asking for more details. So what did you see? What did you hear? What did you feel or smell or taste? Increasing the details. And again, remaining in the body, remaining, kind of habituating to those emotions as they come up. Maybe moving into telling the story in a present tense, so telling it in a way that it's happening to you now. And then finally moving into how you thought, how you felt when that event was actually happening to you. And so again, coming back to the same example of the car accident, we might have our client telling the story of the car accident to the therapist. And so in conclusion, the goals of all of these types of therapeutic techniques are to ultimately decrease the symptoms of PTSD, increase our clients' coping strategies, and create a plan for relapse prevention. And so what we often find is that these strategies, working on the thoughts and working on the emotions, can be really helpful to be used kind of in tandem with one another. Sometimes they're used separately, and it really just depends on, what the trauma was, what might be effective for a specific client. And so again, with the goals of cognitive restructuring being to disconnect from negative thoughts, negative beliefs, and to start shifting into more adaptive beliefs, with the goal of the exposure techniques being to be able to reconnect with memories, with people, with places, and recognizing that the emotions associated with the event and the memories of those events are safe and they are not actually the trauma itself. So thank you so much for listening. I will be happy to answer any questions on the Facebook Live event, and I hope to see you all soon. Thank you.